decanylation phase may be as important as the cannulation phase, because you can have the situation, you've had a wonderfully successful ECMO run, and then you can make a complete mess of the decannulation. I mean, either be back to square one or kill the patient. And there's the possibility for disaster both with cannulation and decannulation. And as I said earlier, extrathoracic cannulation is always preferable. So we've got the various options in terms of modes. So vena-venous, veno-arterial. We've also got options in terms of method. We can either go percutaneous, or we can do cut down and go open, or as we've seen earlier in the previous talks, you can go what we call semi-Seldinger, which is to cut down on the vessels, expose them, see their size and control them, and then actually put the cannulas in over a wire under direct vision. And then obviously there's the issue of cannula type. You have double lumens, as we've seen, and you can have single lumens. And I would add to that that there are wire-wound cannulas and ones that are not. When you're using centrifugal type circuits, there is a distinct advantage to using wire-wound cannulas whenever you can. We've been through this already, the issues about VA and VV in terms of their advantages and disadvantages. VV, one of its advantages, it's much quicker to get the patient on ECMO because you may only need to put a single double lumen catheter in and then you're off. Whereas it's with veno-arterial, there's a bit more fiddling around. You have to control the artery. The arteries are sometimes more difficult to handle, and you need to put a distal perfusion cannula as well. The other point to make, and again reinforce, is that when you're on DV, you have the same oxygen saturation in all the vascular beds of the body, whether it's the coronaries, the brain, the liver, or anywhere else. Whereas if when you're going on VA, you may have different oxygen saturations in different parts of the body, with the most desaturated bit being the coronaries. In terms of what you consider for cannulation, large as possible is usually the way to go, as flow is everything is the old-fashioned ECMO quote. Small venous cannula tends to lead to low flow. A small arterial cannula tends to lead to hemolysis, because the smaller the radius, then the greater the Reynolds number that you will produce. Remember that flow is a fourth power function, so that a small reduction in radius or a small increase in radius will make a significant difference to the power of 4 in the flow. The M number, which stands for Michigan, is a method of trying to standardize the effects of cannulas, because a cannula may come out of the packet as 15 French, and then you compare it with the flow of another one which comes out of a packet which also says 15 French. They may be different. The flow characteristics may be different, and they're different because not only is the wall thickness important, but also you have the effects of side holes. Side holes may produce Bernoulli effects and other effects which you don't easily quantify. And so what you need to know is when you put a particular cannula in, whatever French gauge it says on the packet, what flow will you actually achieve. And the M number is a means of standardizing those flows. The other thing to say is that just putting a certain size cannula in does not guarantee it will work. It's important that you orientate it correctly so that it doesn't occlude against something, because if it goes against the wall of the vessel, then it'll be very ineffective.